Welcome to the Liver Lounge, your go-to podcast for the latest updates in hepatology, featuring discussions with the world's leading experts.
Hi, welcome to the Liver Foundation podcast. I'm Dr. Margaret Ting from National University Hospital, and I'm pleased to have with me today Liv Hetland. She's from the gastro unit of the Copenhagen University Hospital in Denmark. And I think Liv has recently published an article in Hepatology Communications titled Suboptimal Diagnostic Accuracy of Ultrasound and CT for Compensated Cirrhosis, Evidence from Prospective Cohort Studies. So hi Liv, thanks a lot for agreeing to this discussion. Without further ado, maybe we will just start to discuss the article that you wrote. And before we dive into that, may I just ask what is the current evidence regarding diagnostic accuracy of ultrasound and CT scan for cirrhosis, and what actually prompted your group to kind of explore this in further detail?
So regarding the evidence of the diagnostic accuracy for cirrhosis for ultrasound and CT, these studies are usually specific for radiology, where they implement these specific techniques to increase the sensitivity. Like for ultrasound, it could be a shear wave elastography or Doppler, and for CT, it could be different contrast protocols. And usually in cirrhosis studies, it's being performed on patients with viral chronic hepatitis or alcoholic-related liver disease. So patients with NAFLD or NASH cirrhosis has been underrepresented. And we know they have an atypical, atypical morphology of cirrhosis also on imaging. So we wanted to explore it because in our inpatient department, we have several times had patients admitted with, for example, bleeding, esophageal varices, with an unrecognized liver cirrhosis, which was not evident on previous recent imaging.
And what would some of the diagnostic features of cirrhosis be on ultrasound and CT scan that you know about?
So you would look in both ultrasound and CT scan, you will look at the liver morphology, like what the liver looks like, and you would look for signs of portal hypertension. So the liver morphology, the classical cirrhotic liver, it's usually small or shrunken, and it has a nodular surface, a coarse echo pattern, a heterogeneous density, and the portal hypertension signs are dilatation of the portal or splenic or superior mesenteric vein. But here, I think it's also important to note that this is for the classical cirrhotic studies on the radiology studies on the cirrhosis. So it's not necessarily typical for NAFLD or NASH patients.
And just out of curiosity, like for these, because you mentioned that you have been seeing a lot of patients with NAFLD or NASH with first presentation with complications of cirrhosis, and yet their imaging doesn't really have any features of cirrhosis. In these patients, have they had transient elastography done before? And what is your experience in terms of using transient elastography to screen for advanced fibrosis or cirrhosis?
So the patients in question, which presented with, decompensation, they were previously unrecognized. They weren't being examined for anything with the liver. This was the first visit in the health system. We use transient elastography on all our patients, and we find it as a really good tool to screen for, do you need further evaluation, which is usually a liver biopsy, probably together with a liver venous catheterization, or can we rule it out? Because that is actually good in ruling out cirrhosis if it's normal.
Indeed. So thanks a lot for this kind of background to the study. Maybe, Liv, you can help us to maybe describe the study design?
Yes. So in our research department, we usually have several studies on the different liver diseases going at the same time. So for this study, we used 4 of our studies one on NAFLD patients, two on cirrhotic patients of all causes, which was mainly alcoholic-related liver disease, and one study on rare liver diseases, which comprised the autoimmune and the PBC, PSC, and so on. So we pooled these studies together to get a high number of biopsied patients. And the whole point of the study was to mimic an everyday clinical setting where you have a patient with a suspected liver disease. This could be patients referred to an outpatient clinic with the elevated liver enzymes, or a steatotic liver on an ultrasound from primary care. It could be clinical or paraclinical findings or medical history suspecting either alcoholic liver disease or the autoimmune or rare liver diseases. And what you do with these patients are you assess them and you order the relevant examinations, but you of course look in the medical file. And very often a patient will have an imaging of the abdomen, either by ultrasound or CT of any indication. And we used the images where the liver was described, but the imaging could be booked on any indication. So it didn't have to be liver specific. So this would mimic best our everyday clinical practice. So then we manually looked up all these 377 patients, and we registered the results and performed the analysis.
Okay, that's a pretty succinct kind of summary of your study design. Can I just ask, were the imaging done before or after the biopsies, and you only included patients who had already undergone a liver biopsy, so this is kind of retrospective, correct?
Yeah, we included imaging if it was done 18 months before or 3 months after the biopsy, to just have a sort of picture around the biopsy, because most liver diseases are not that fast progressing. So we concluded that the 18 months before would probably still look like the liver at the time of biopsy. But the median was around 3 months before and after.
Okay, that's great. And in terms of analyzing the imaging, do you rely on the reports, or you got like kind of liver expert radiologists to kind of look at the images and for all 370 patients?
No, we read the descriptions ourselves, and if the liver was described, it was usually described as this or that, so either normal or cirrhosis or something in between. And if we were uncertain, or if the radiologist was uncertain at the description, we had our specialist radiologist reassessing the uncertain images. So we got this cirrhosis, yes or no.
Okay, I see. So, I mean, so maybe you could also now kind of summarize your study results, and then we can discuss this a little further.
Yes. So we ended up with 377 patients who had both a biopsy and either an ultrasound or CT scan or both. And 220 of these were from our NAFLD cohort, and the rest was from our alcoholic liver disease cohorts, cirrhosis cohorts, and the rare liver disease cohorts. And then we performed the diagnostic accuracy calculations on the whole group, and also we divided the group into the compensated and decompensated cirrhosis, and we also did a subgroup analysis on the NAFLD patients only. And these results confirmed our clinical suspicion that cirrhosis can be hard to catch, especially in the NAFLD patients. And compensated cirrhosis is hard to rule out because the sensitivity was really low. For the NAFLD group, for the NASH cirrhosis, the sensitivity of ultrasound was 45%. Which is terrible because there's a lot of false negatives. You can't really find most of the patients with compensated NASH cirrhosis with ultrasound. And for CT, it was 60, so that's also bad. It was better when we pulled them together, like the whole compensated versus decompensated group, and also the whole group of cirrhosis as a whole, because then you also have the child pew B and C, which is easier to find. So it has higher sensitivity. But we were, the results on the NAFLD group was, it was almost a little bit shocking. That was so bad.
Yeah. So I mean, I think you've mentioned two major points I think that your study has kind of managed to find out or discover. And I would like to ask you about these 2 points. So first, my first question would be, why do you think the diagnostic accuracy in patients with NAFLD or NASH would be lower? And the second question would be, why would the diagnostic accuracy of imaging for compensated cirrhosis be lower compared to decompensated cirrhosis?
So for the NAFLD cirrhosis, the reason it's so low is because they're not obvious. The patients are not an obvious cirrhosis, either clinical or paraclinical or on imaging, because they can walk in to the outpatient clinic being in full jobs, having maybe some elevated liver enzymes for a few months, maybe fluctuating for a few years. They can have a normal imaging. And this is what any NAFLD patient looks like, also those without fibrosis or fibrosis stage 1 or 2. So you can't really separate them this early. Because we know also that the NASH cirrhosis liver, it doesn't always present like the classical cirrhotic liver, because this might still be enlarged and steatotic. So this will, of course, translate to the scan, the imaging, where it looks like this typical NAFLD steatotic liver, maybe because it's such an early stage that it's between the third stage of fibrosis towards the cirrhosis. But also it might be that the NAFLD liver is morphologically different than the chronic viral hepatitis and the alcoholic liver disease when it progresses to cirrhosis.
Okay. I mean, I think in your study, it kind of looked like the characteristics, like the demographics of the patients. It did seem that the NAFLD patients were not more obese, or were they? I don't think that they were more obese, right? Or actually, those that were cirrhotic were not more obese than those that were not cirrhotic. So I'm not sure how much of the findings. I mean, as you mentioned, it could be that the NAFLD liver morphologically, there's more steatosis, and therefore morphologically it's larger and more difficult to pick up. But anyway, I think the other point I wanted to kind of ask was about compensated versus decompensated patients. Why do you think that in the compensated or early stage would the liver not have already had signs of cirrhosis, or would do you think that there would be other features that could help us to identify compensated cirrhosis at the earlier stage on imaging?
Yeah, that's a good question. And that would be really great if we had something we could use, especially if it's not invasive. But that's the whole point of this study, is that it's so hard to find the compensated cirrhotic patients, and especially in NAFLD, as I just said, but also in the alcoholic liver diseases and the autoimmune and special liver disease. But it seemed like it didn't seem like it was all of our misdiagnosed patients were compensated Child-Pugh A, and most of them were NAFLD, but some of them were also the other etiologies. And it's because it's hard to find, because that's the thing about cirrhosis. Suddenly it shifts and you get portal hypertension, decompensation, and all these symptoms, and then it's too late. So we really need to find something early on that could give us a better hint. And I think the transient elastography is absolutely the best tool we have now, but that's also, it's not perfect
indeed
either.
Indeed. Yeah. And I think so I think the message of the study is very clear, and it's a very good message to kind of say that we need to be more careful to look out for cirrhosis, because compensated cirrhosis and NAFLD cirrhosis is often not diagnosed on imaging. Let's shift gears a bit. Let me just ask about the difference between ultrasound and CT scan. I think in your study, the sensitivity or the diagnostic accuracy for both imaging modalities was seem to be quite similar.
Mm.
But I think if you look at previous retrospective studies, and I think your paper did cite some of these previous retrospective studies, actually ultrasound has a kind of poor sensitivity than CT scan. So maybe you could comment on why do you think that would be the case?
Well, I think that just in general, ultrasound has a higher rate of intra and inter-observer variability, and it also have the downfalls of being less accurate if the patient is obese or has a lot of bowel gas or bowel movements. So it's a more sensitive diagnostic tool because it's very dependent on these factors. And this is also one of the things with NAFLD patients, they're usually obese. But with CT, it's more standardized, and it's with the less intra and inter-observer variability. It's more clear, and they have also some good cirrhotic scoring criteria that has been developed. And some of the things are easier to see. Some of the morphologies and the portal hypertension signs are easier to see on a CT scan. So the sensitivity is higher, yes, on CT.
So maybe I can ask, based on your study's findings, what do you think the clinical applicability of the results would be?
Sorry, can you say that once more?
Yeah, sure. So I think based on your study's main findings, how do you think that this would translate clinically, or how would you modify or kind of change your clinical practice based on these studies' findings?
Well, I think it's important to always, to never disregard the cirrhotic diagnosis based on an imaging. And that also includes the transient elastography, which is better, but still not perfect. And I think you have to really make up a really thorough picture of these patients with clinical, paraclinical, biochemical, and radiological signs. And if you're in doubt and you believe something is wrong, I think it's the right thing to do to have the patient perform a liver biopsy with the liver venous catheterization, the transjugular one with the less potential risks. But this isn't available in all centers. So for us, I think the best tools we have are the transient elastography, the fibrosis 4 index. And if it's available, the enhanced liver fibrosis score, the ELF score. Yeah.
So may I just ask, I mean, you mentioned that there are a lot of studies going on in your unit at the moment. So based on the results of this study, are you planning to develop any further studies, or what do you think are the future directions for research, in particular in this area?
I would love to see a study which is goal-oriented towards the NASH cirrhosis, because it's so obvious that it's a little bit different than the classical cirrhosis. And it's so important to find at an early stage, because more and more patients are developing this. It's going to be like the #1 reason for a liver transplant within the next years. And with NASH cirrhosis, some studies are, phase 2 and 3 studies. Some medication might be able to at least stop the progression of the cirrhosis, which can lead to a longer life. So I would love to see a study on a large NAFLD cohort where all the fibrosis stages are represented, with both compensated and decompensated cirrhotic patients. And all these patients should perform an ultrasound or CT scan just before or after a liver biopsy. And these results could be compared to our results, where the indication was at random or all-cause indication of the scan. So this way you can compare, can the targeted liver scan in NAFLD patients obtain a better sensitivity than the all-cause indication scan. And also with this type of study, you could better describe the morphology of the NASH cirrhosis liver, cirrhotic liver, because this is yet to be officially described. We know it's atypical, but no one has done this study yet, and I would love to see it.
Yeah, so that sounds like a great idea. And maybe I think in future, perhaps artificial intelligence now I think is something that's very topical. Maybe that would be something that could help us to identify features of NASH on imaging in patients with undiagnosed cirrhosis. So congratulations on this great study, Dr. Hetland. And thank you very much for agreeing to this interview. Yeah. So before I close, is there anything else that you would like to add about the study?
Just that never disregard cirrhosis if you get a negative scan. It's very important.
That's a great message for all our listeners. So thank you very much for taking your time to be part of this podcast, and thanks to all the listeners out there. Thank you.
We have come to the end of the episode. Thank you for joining us and stay tuned for more captivating discussions.